Okay, so you want to own a pharmacy. You picture a small storefront with a green cross glowing in the window, a line of regulars picking up blood pressure pills and cough syrup, and a quiet, steady business built on something every single person eventually needs. People get sick, people get old, people need the same prescriptions filled every month for the rest of their lives. It sounds like the closest thing to a recession-proof business that still exists. Here's the catch. In 2023, more than 80% of every prescription filled in the United States was for a generic drug, not a brand name. And generics, the very drugs everyone assumes are the bread and butter of a pharmacy, often produce the thinnest profit of anything on the shelf. A pharmacy can fill a prescription perfectly. Hand over the exact right pills, in the exact right bottle, follow every single rule to the letter, and still lose money on that one transaction the moment the paperwork clears. Not because the pharmacist did anything wrong, because somebody else, a company the patient standing at the counter has never heard of, already decided what that prescription was worth weeks before the patient ever walked in. So if pharmacies are constantly handing out products worth hundreds of thousands of dollars a month, why do so many owners struggle to pay themselves a living wage? The answer starts with what it actually costs to open the doors in the first place. Getting into this business does not start with buying medicine. It starts with paperwork, and the paperwork is not cheap. A pharmacist in charge license, state pharmacy permit, a federal registration with the Drug Enforcement Administration just to legally handle controlled substances. Enrollment with Medicare and Medicaid, which alone can take up to 3 months. State permits can take anywhere from 2 to 4 months on their own. Add the build-out of the physical space, the plumbing, the electrical work for refrigeration units, the shelving, the counting machines, the point-of-sale software, and you are looking at a realistic all-in startup cost somewhere between $400,000 and $800,000 before a single customer walks through the door. One detailed breakdown of a typical independent pharmacy launch puts the total cash needed by month 6, once you include payroll before the doors even open and enough working capital to survive the slow first months, at around $647,000. And that number is before you've stocked a single shelf. Opening inventory alone can run $70,000, $80,000, even $100,000, because pharmacies cannot simply stock a little of everything. You need enough of the right drugs, in the right quantities, sitting on a shelf, waiting for a prescription that might come in tomorrow or might not come in for a month. Technology alone, the pharmacy management software, the verification systems, the security cameras required to track controlled substances, typically costs another $25,000 to $50,000 just to get running. There are really 2 paths into this business, and the price tag changes depending on which one you pick. The cheapest way in looks like buying an existing, already licensed independent pharmacy with an established patient base and existing insurance contracts already in place. It sounds like the obvious choice, since someone else already absorbed the licensing delays and the slow first months of near-zero revenue. But existing pharmacies rarely sell cheap, because a buyer is also paying for goodwill, for the years of trust the previous owner built with the community, and for a patient list that took a decade to assemble. The more expensive path is building a brand new pharmacy from an empty commercial space, which costs less upfront in goodwill but far more in construction, permitting delays, and the months of paying full rent and insurance with no revenue at all coming through the door. Neither path is the cheap one. One trades cash for time. The other trades time for cash. Most new owners plan for 6 to 12 months between deciding to open a pharmacy and actually opening it. And here's where the first hidden cost creeps in. Every month of delay is a month of rent, insurance, and loan payments with zero revenue coming in. Contractors run late. Inspections get rescheduled. Insurance credentialing, the process of getting approved to bill insurance companies at all, can take another 30 to 90 days on top of everything else. Owners who budget 6 months of pre-opening costs frequently find themselves paying for 9 or 10, so the doors finally open. Now the real costs begin. First, rent, which in a decent retail location can easily consume 10 to 20% of monthly revenue before anything else is paid. Second, labor, which for a pharmacy is not optional overhead the way it might be for a retail shop, because federal and state law require a licensed pharmacist on site at all times the pharmacy is open, and pharmacists command real salaries. The median pay for a pharmacist in the United States was $136,030 a year as of 2023. Multiply that across the hours a pharmacy needs to stay open, add pharmacy technicians, cashiers, and a pharmacist in charge who often earns more. And payroll becomes the single largest line item most owners face, frequently outpacing every other expense combined. Third, insurance. Liability insurance, property insurance, and the kind of professional liability coverage a business handling controlled substances simply cannot operate without. Fourth, inventory financing. As pharmacies begin stocking increasingly expensive specialty medications, the cost of simply carrying that inventory on a line of credit, waiting for reimbursement, starts eating into cash flow before a single one of those drugs is even sold. And this is where most first-time owners make their first mistake. They assume that once the drugs are on the shelf, the money that comes back from selling them is simple. It is not. Because the price a pharmacy pays for a drug and the price it gets reimbursed for that same drug are set by two completely different forces, and the second one is not something the pharmacy controls at all. Meet the three companies that quietly decide what almost every pharmacy in America gets paid. They're called pharmacy benefit managers, or PBMs for short, and here's the simplest way to understand what one actually does. Imagine you're the pharmacy. You buy a bottle of pills from a wholesaler for $80. A patient's insurance plan hires a middle company to negotiate, on the insurance plan's behalf, exactly how much you will be paid when you hand that bottle over. That middle company is the PBM. It never touches the medicine. It never sees the patient. But it decides down to the penny whether you make money or lose money on that bottle. A pharmacy might charge $100 for a drug and discover after the claim processes that the PBM will only pay $92 for it. The contract explaining exactly why is often thousands of pages long, filled with reimbursement formulas that even experienced pharmacy owners describe as nearly impossible to fully decode. There are three of these companies that matter more than every other player in the industry combined. CVS Caremark, owned by CVS Health, Express Scripts, owned by the insurance giant Cigna, and Optum Rx, owned by United Health Group, the largest health insurer in the country. Together, these three process roughly 80% of every prescription claim filed in the United States. Not 80% of some niche segment. 80% of the entire national prescription market runs through three companies most patients standing at the pharmacy counter could not name if you asked them. In 2024, Express Scripts overtook CVS Caremark as the single largest player, processing 30% of all claims nationwide, after winning a 5-year contract to manage benefits for 20 million people previously served by its biggest rival. CVS Caremark still processed 27%. Optum Rx processed 23%. Here's why that concentration matters so much. When three companies control 80% of the customers a pharmacy can possibly serve, a pharmacy does not really negotiate with them. It accepts what it's offered, or it stops being able to fill prescriptions for 80% of the patients walking through its door. And increasingly, these three PBMs are not neutral middlemen sitting between insurers and pharmacies. 5 of the 6 largest PBMs in the country are now owned by companies that also own a health insurer, meaning the same corporate parent that decides how much your pharmacy gets paid may also own competing pharmacies down the street. So far, so good, if a little unsettling. Now let's talk about what can go wrong once that contract is signed. Sounds like a straightforward, if lopsided, business relationship? Well, almost. Here's the problem. Sometimes, a pharmacy fills a prescription and loses money on it every single time. Not occasionally, not as a rare mistake, but as a mathematical certainty built into the contract. This is called negative reimbursement, and it happens when the price the pharmacy paid to acquire the drug is higher than what the PBM will pay the pharmacy back. A pharmacy might pay $150 for a medication and receive only $140 in reimbursement. Every bottle sold at that price is a guaranteed loss, and owners often keep filling the prescription anyway, because refusing to fill it means losing the patient entirely, possibly for good. And then there's the part that makes the whole system feel less like a business deal and more like a trapdoor hidden under the floor. For years, PBMs were allowed to reach back into a pharmacy's bank account months after a prescription had already been filled and take money back. These are called direct and indirect remuneration fees, or DR fees, and the mechanism works like this. A pharmacy fills a prescription, gets paid, and believes the transaction is closed. Then, sometime 6 months later, the PBM assesses a fee tied to performance metrics, things like how many generic drugs the pharmacy dispensed or how well patients stuck to their medication schedules, and claws back a percentage of what it already paid. One government estimate found these retroactive fees grew by more than 100,000% between 2010 and 2020. As a share of total prescription sales, they grew from under 0.5% in 2015 to nearly 4% in 2023. Imagine running a shop where every sale you make this month might quietly get discounted after the fact, sometime around the holidays, and you won't find out by how much until the bill arrives. Owners compared it to discovering, months later, that every single sale had secretly been marked down without anyone telling them at the register. Forecasting cash flow under those conditions is nearly impossible because a pharmacy genuinely does not know whether last month was profitable until long after the month has ended. Federal regulators eventually stepped in. Starting on the first day of January in 2024, a new rule required these fees to be assessed immediately at the point of sale rather than clawed back months later. That fixed the timing problem. It did not fix the size of the fee. The money still leaves the pharmacy. It just leaves faster now and with a different name, performance fees or performance adjustments. Given all of that, you might ask a very reasonable question. If drugs themselves are this financially dangerous to sell, where does a pharmacy's actual profit come from? Mostly not from the drugs. Dispensing fees, front-of-store retail sales, flu shots and other vaccinations, medication therapy consultations, and diagnostic testing services frequently generate more real profit than the prescriptions themselves. A bottle of a common generic medication that costs the pharmacy around $4 can produce less profit than a single greeting card sold at the front register. High-volume pharmacies survive on thousands of small, low-margin transactions rather than a handful of lucrative prescriptions, the exact opposite of what most first-time owners expect walking in. The layout of the store itself becomes part of the revenue strategy. The shelves near the register, stocked with over-the-counter products, greeting cards, and seasonal items, are arranged deliberately to catch a customer's eye while they wait for a prescription to be filled, because those higher-margin front-of-store items can carry profit margins several times higher than the prescriptions themselves. Medication therapy management, a service where a pharmacist sits down with a patient managing multiple chronic prescriptions and reviews everything they're taking for dangerous interactions or unnecessary duplication, generates a fee for the pharmacy's time and expertise rather than for a physical product at all. It is, in a very real sense, the pharmacy selling its knowledge rather than its inventory, and it is often more profitable per hour than standing at the counter counting pills. Vaccinations reshaped this equation dramatically. During the COVID-19 pandemic, some pharmacy locations administered hundreds of shots in a single day, turning pharmacists into one of the most important vaccination networks in the entire country almost overnight. That single service line, something that barely existed in most pharmacies a decade earlier, became a meaningful chunk of total revenue for many independent owners. Here's what the overall numbers actually look like. Across the industry, the average independent pharmacy pulls in something like $3 million a year in total revenue. Its gross profit margin, meaning the percentage left over after paying for the drugs and products themselves, sits at roughly 21 to 22%, a number that has barely moved in a decade despite everything happening underneath it. But gross margin is not the number that matters. Net margin is. After paying rent, salaries, insurance, and every other operating cost, the average independent pharmacy keeps somewhere between 2 and 5% of total revenue as actual profit. On $3 million in revenue, that can translate to a net profit in the range of $60,000 to $150,000 a year, which then has to cover the owner's own salary, as well as whatever they hope to earn for taking on all of this risk in the first place. So more prescriptions should mean more profit. It doesn't, not automatically, and here's why that math breaks down. Every additional prescription filled adds labor, inventory financing, insurance exposure, and compliance paperwork. A pharmacy filling 500 prescriptions a day at a small loss on each one can go out of business faster than a pharmacy filling 200 a day profitably. Some owners discover, after reviewing their own numbers, that their busiest insurance plans, the ones sending the most patients through the door, are actually their least profitable customers. Growth in this business can quietly create a cash trap. Revenue climbs on paper while the actual cash sitting in the bank account shrinks, because more prescriptions simply means more exposure to the reimbursement math working against you. Now remember what I said earlier about the drugs themselves being unpredictable. That unpredictability gets dramatically worse the moment specialty medications enter the picture. Specialty drugs, the medications used to treat cancer, multiple sclerosis, and rare genetic conditions, can cost anywhere from $600 to well over $10,000 for a single month's supply. These drugs make up only around 4% of all prescriptions filled in the country, yet they account for roughly 70% of total prescription drug spending nationwide. That is an enormous amount of money flowing through an extremely small number of transactions, and it cuts both ways. A pharmacy that successfully fills specialty prescriptions can generate more revenue from a handful of patients than an entire month of ordinary generic fills. But specialty pharmacy requires cold chain shipping, refrigerated storage, ongoing patient monitoring, and insurance approval processes that can take weeks. And PBMs frequently require patients to use the PBM's own affiliated specialty pharmacy rather than an independent one nearby, cutting most independent owners out of this lucrative category entirely. And when an independent pharmacy does manage to dispense one of these high-cost drugs, the negative reimbursement problem gets magnified enormously. Trade publications covering the industry have documented cases where a single fill of a high-cost specialty medication, reimbursed below acquisition cost the dispensing pharmacy more than $11,000 in a single transaction. One fill, one patient. $11,000 gone, and the pharmacy usually has no way to know it's happening until the reconciliation report arrives, sometimes months later. This is the volatility at the center of the entire business. The costs, rent, salaries, licensing, insurance, are fixed and predictable. The revenue is not. And when an entire industry's profit depends on a variable it does not control, eventually the mismatch shows up in the real world, not as a number on a spreadsheet, but as stores closing their doors for good. By 2021, nearly 30% of the roughly 89,000 retail pharmacies operating in the United States a decade earlier had closed, more than 26,000 stores gone. Independent pharmacies and pharmacies serving predominantly Black and Latino neighborhoods closed at higher rates than anywhere else. Among rural independent pharmacies specifically, about 10% closed between 2013 and 2022. One research group found that 80% of rural independent pharmacies were being reimbursed less than what it actually cost them to acquire and dispense the medication, meaning the majority of small-town pharmacies in America were losing money on the basic act of filling a prescription, before counting rent or a single hour of payroll. By 2024, the National Community Pharmacists Association projected that more than one independent pharmacy would close, on average, every single day of the year. The chains were not immune either. Rite Aid, unable to escape years of declining reimbursements and mounting debt, filed for bankruptcy and began closing hundreds of stores across more than a dozen states. Shortly after, Walgreens announced plans to close roughly a quarter of its entire store footprint nationwide, more than 2,000 locations. These are not small regional operators struggling in isolation. These are some of the largest pharmacy chains in American history, closing stores by the thousands, in the same years that prescription drug spending in the country was climbing past $700 billion annually. Here's the structural observation, the one that connects all of this to the pharmacy you were imagining at the very beginning. In 2007, CVS, at the time still primarily a drugstore chain, bought Caremark, one of the largest PBMs in the country. In 2018, it went further, acquiring the health insurer Aetna for $69 billion, creating a single company that now owns the insurance plan, owns the PBM that decides reimbursement rates, and owns thousands of retail pharmacies competing directly against every independent pharmacy in the country. United Health Group did the same thing with its own Optum Rx business. According to a Federal Trade Commission investigation, the four largest vertically integrated health companies in America together captured just 14% of all healthcare dollars spent nationwide back in 2016. By 2023, that share had grown to 22%, more than a fifth of all healthcare spending in the entire country, worth over $1 trillion a year, up from $456 billion just 7 years earlier. The same investigation found that PBMs had captured 68% of all revenue generated from dispensing specialty drugs in 2023, and appeared to be steering the most profitable prescriptions toward pharmacies the PBMs themselves owned, while independent pharmacies were left with the lower margin, higher risk transactions everyone else didn't want. To be fair, the PBMs don't describe it that way. A CVS Caremark spokesperson has pointed out that independent pharmacies still make up more than 40% of the pharmacies in its network, and that in at least one state, independent pharmacies were actually reimbursed at a noticeably higher rate than the chain's own company-owned stores. That's a real data point, and it's worth holding alongside everything else, because the picture is not a simple story of a villain crushing every small business in its path. It's messier than that. Some independent pharmacies negotiate reasonably well. Many others, especially in rural and lower-income areas with less leverage and fewer competing PBM contracts to choose from, do not. Keep this in mind if you're picturing yourself as the small shop on the corner, competing against a company that also owns the insurance plan sending you customers, the middleman deciding what you get paid for serving them, and, increasingly, a rival pharmacy down the street under the very same corporate roof. There's one more expense hiding inside all of this, and it isn't a dollar figure on a balance sheet. It's the people for years, Pharmacists across the country have described being buried under a growing list of duties that goes far beyond counting pills. Filling and verifying prescriptions is still the core job, but pharmacists are also expected to run vaccination programs, resolve insurance rejections over the phone, handle prior authorizations, manage drug shortages, and field a steady stream of customer calls, sometimes 8 to 10 an hour, each one taking up to 15 minutes to resolve. One survey found that 71% of pharmacists reported a high or excessive workload even before the pandemic began, with a burnout rate above 60%. Then came COVID-19, and pharmacies absorbed testing, vaccinations, and a flood of new patients almost overnight, on top of everything they were already doing. The pressure eventually became visible to the public. In the fall of 2023, pharmacy staff at CVS, Walgreens, and Rite Aid locations across the country staged coordinated walkouts, refusing to work over concerns that understaffing was putting patients at risk of medication errors. It wasn't a fight over pay. It was a fight over having enough people on the schedule to do the job safely at all. The walkouts spread from a dozen stores in the Kansas City area to locations nationwide within weeks, arriving in the very same season Rite Aid filed for bankruptcy, and every major chain was closing stores. Here's the pivot this forced. If labor is this expensive and this hard to keep staffed, can technology quietly take its place? The big chains are betting heavily that it can. Walgreens has poured money into robotic micro-fulfillment centers, large automated facilities that can process and package prescriptions with far less manual handling than a pharmacist standing behind a counter. By the company's own account, those centers have already generated approximately $500 million in savings by trimming excess inventory and speeding up fulfillment. Central fill facilities let chains prepare medications at scale in distribution centers and ship them out to individual stores, more Amazon warehouse than neighborhood pharmacy. For an independent owner, none of that scale is available. You either staff every shift with expensive, licensed labor, or you don't open at all, and every dollar spent on automation to fix the labor problem is a dollar an independent pharmacy usually doesn't have. And underneath all of this sits one more twist that makes the entire picture stranger. Demand for pharmacies isn't shrinking. It's growing, and it keeps growing every single year. Every member of the American baby boomer generation, more than 70 million people, will be at least 65 years old by 2030, and older adults fill far more prescriptions, on average, than any other age group. Chronic disease management, for conditions like diabetes and high blood pressure, keeps expanding the sheer number of prescriptions filled every year across the entire country. On paper, more prescriptions should mean more business for everyone in the industry. In practice, rising demand and rising financial vulnerability have grown side by side, because the industry's winners are increasingly the companies capturing value through specialty drugs, integrated insurance networks, and automation, not the ones simply filling more bottles by hand behind the counter. So, let's actually do the math on what a year in this business looks like. Starting with the version where things go reasonably well, in an optimistic year, your pharmacy generates around $3 million in total revenue, roughly in line with the national independent average. Your gross margin holds at 22%, in line with industry norms, giving you around $660,000 to cover every operating cost. Rent, insurance, and overhead consume somewhere around $180,000 of that. Payroll, the largest expense by far, including your own pharmacist's salary and support staff, takes another $340,000. What's left, roughly $140,000, is your net profit for the year, the number that has to cover both your take-home pay and any return on the $650,000 or so you originally put to opening the doors. Now here's the realistic year, the one built from what actually happens to pharmacies across the country rather than what the business plan promised. A meaningful share of your prescriptions, the specialty fills, and the high-cost generics affected by sudden price spikes get reimbursed below your acquisition cost, the negative reimbursement problem described earlier. Performance fees deducted at the point of sale shave another 1 to 2 percentage points directly off your margin. One or two of your largest insurance plans renegotiate their reimbursement rates downward, same pressure that pushed 80% of rural pharmacies below their break-even point. Net margin, instead of holding at 4 or 5%, collapses toward 1% or turns negative entirely. That $140,000 in profit doesn't just shrink. It can turn into a loss of $10,000 or $20,000 for the year, even though you filled just as many prescriptions, served just as many patients, and made not a single operational mistake. The difference between a good year and a bad year in this business is not measured in how many customers walked through your door. It's measured in about $150,000 And almost none of that swing is something the pharmacy itself controls. Roughly 15 million Americans depend specifically on independently owned pharmacies rather than a large chain, and research on who those patients actually are tells its own story. They tend to have lower incomes than average. They're more likely to live in rural areas, far from the nearest big-box drugstore. And they're more likely to be over the age of 65, managing several prescriptions at once, needing exactly the kind of one-on-one counseling a 15-second interaction at a busy chain counter simply cannot provide. When one of these pharmacies closes, the community doesn't just lose a place to pick up medicine. It often loses its most accessible point of contact with the entire healthcare system in places where the next nearest option might be 30 minutes away or more. So, if you do decide to open a pharmacy, remember what's actually being sold across that counter. It was never really the pills. The pills, more often than not, are the least profitable part of the entire transaction, priced by contracts you didn't write, clawed back by companies you'll never meet, and increasingly funneled toward pharmacies owned by the very same companies deciding what you get paid. What a pharmacy actually sells is trust, convenience, and access to a healthcare system most people don't understand well enough to navigate alone. The owners who survive this business long-term are rarely the ones who fill the most prescriptions. They're the ones who figured out early that the prescription was never really the product.